This talk will cover a few topics related to prescribing safety and how we can improve that within critical care. So our unit currently uses a paper drug Cardex, which are becoming increasingly unfamiliar beasts in our electronic world, and therefore they're full of danger. We're now going to go through what our pharmacist calls her little drug chart of horrors to spot the errors and discuss how we can avoid making them. So here you can see the drug has been prescribed but not given, and this is usually caused by a lack of communication. So we've prescribed something but we've not told anyone about it, and we've expected them to just telepathically know that we've prescribed something. So there's a few things we can do about this. Well, simply we can just make sure the bedside nurse is told about all new prescriptions so that they know what's been changed. This is just common sense. We can also stick a medication change sticker on the OBS chart in the communication boxes on the side. And this is just a reminder, this doesn't replace the face-to-face communication. Here we can see that tazocin is prescribed, and what the eagle-eyed amongst you on the front page will have spotted is that the patient's allergic to penicillin, and tazocin is piperacillin and tazobactam. It's also not a formulary choice for CAP, which is what it's prescribed for. Here is our microbiology guidelines for community-acquired pneumonia, highlighting the importance of microbiological investigations, and the recommended for severe pneumonia would be amoxicillin and clarithromycin, and if they're very sick, a stat dose of gentamicin. Here, where the patient is allergic to penicillin, ticaplain and clarithromycin would be the choice. Also, there's no route for clarithromycin. It's important to fill in all the boxes. This is our gentamicin prescription page in the Cardex, designed to make gentamicin prescribing easier and safer, but still fraught with danger. So the gentamicin level hasn't been sent here because this should be signed. So a dose should be given, and then you should send a level 8 to 12 hours after the initial dose, even if you've only given a stat dose. And this is because if we do decide later on to give more gentamicin, we have a level then, so we know how much to give and when. They may have had gentamicin in the emergency department, so it's important to check their documentation as well. And then any subsequent dosing and the intervals between dosing should be advised by pharmacy. Here we see no patient label. You do need a label in each addressograph box so that when the Cardex is scanned in, we know which patient each page is for. Here you can see that the drug has been prescribed but not given, so it's important to check the drugs are being given, and if they're not, why. It may be something simple like a drug is prescribed PO or NG but a patient's nil by mouth or doesn't have an NG, so it's important to consider these things. Again, someone here has forgotten to sign the box, so therefore the drug is not actually prescribed and shouldn't be given. It's also not first line in our bowel protocol, so our bowel protocol states that all patients are prescribed Senna and Docusate unless there's a contraindication to laxatives. And if they haven't opened their bowels at 48 hours, they should have Macrogol started 1 sachet BD. If they still haven't opened their bowels at 72 hours, they should have a PR, and they should have some suppositories. We tend to give glycerin and bisacodal together. If this still doesn't work, then we tend to give a phosphate enema following that. And if the rectum's truly empty, then we need to consider why that is. So have they got an ileus? Do they have a bowel obstruction? So it might be time to think more carefully at that point. Here, dalteparin is prescribed but is missing a dose. We now use enoxaparin, and there is guidance out there on our prescribing information on how to dose enoxaparin. Here, lansoprazole is prescribed IV. It should be oral or NG, if they need an IV PPI, it would be pantoprazole we would use. Patient on the front of the Cardex, the weight was stated as 45 kilos, so the dose here should be reduced. The dose of paracetamol is 15 milligram per kilo for those less than 50 kilos. Here we have clonidine written as milligrams instead of micrograms. Now it's difficult to tell whether somebody's written mcg and it just looks like an mg, or whether they've actually prescribed it wrong. But either way, this could result in a massive dose of clonidine being given. So if a drug is prescribed in micrograms, we should always write micrograms out in full. Here, Lantus is prescribed, and it's impossible to tell whether this is 200 units or 20 units. And again, this can result in massive administration errors and a drug being given at many orders of magnitude larger than was intended. So for insulin, units must always be written out in full. And here, nobody knows what this drug says. So please take an effort to actually write it carefully and clearly so that everyone knows what drug it is. It also doesn't have a start date, so please put a start date when you prescribe a drug. Again, there's a missing addressograph label here. And you may have spotted on a previous slide that paracetamol was prescribed regularly, and here it's prescribed PRN as well, so this could result in an overdose. We've also said that patients less than 50 kilos, so the dose should be reduced, and they also haven't signed the prescription. And then amiodarone here is prescribed in the as required section when it should be required. It should be prescribed in the infusion section. It's also missing details, so missing things like indication, maximum dose, that sort of thing. Here, the rate for the propofol is too high for a 45 kilo patient, so it's important to remember that we use 2% propofol infusions, and the maximum dose will be 3 milligram per kilo per hour, which when you work that out is 0.15 mil per kilo per hour. So for a 70 kilo patient, a max rate would be about 10.5 mils an hour. So prescribing it as 0 to 10 for most patients is a good starting point. And again, the alfentanil has a squiggle but no name. Again, addressograph missing. You'll notice a trend here. And vasopressin has no rate prescribed. So vasopressin has a standard rate. So we use 20 units made up to 50 mils in saline or dextrose, and the infusion rate is 1.5 to 6 mils per hour. There is a cheat sheet available, so if you go to luff.icu/drug or scan this QR code, it will take you to a cheat sheet where all the commonly prescribed drugs are available to help you prescribe them safely. Also, remember to use the antibiotic formulary. Don't forget to check if they've had a dose of gentamicin prior to critical care admission before prescribing. Culture everything, and don't forget that non-directed BAL is a very useful method of getting microbiological samples. Now, it's important to remember that critically ill patients are very high risk for venous thromboembolism, so the few contraindications that we do have would be low platelets if they're less than 50, an INR over 1.5, though we may decide to give it in liver patients as we know that their coagulation is disordered in a balanced way. If they have an intracranial hemorrhage, or if they're very high risk of bleeding, for example active GI hemorrhage, and we'd usually err on the side of giving it, and if in doubt check with the consultant. Enoxaparin is our first line low molecular weight heparin we use for both prophylaxis and treatment dose anticoagulation. The vast majority of patients will receive 40 milligrams once a day. If a patient's over 100 kilos, we would tend to give 40 milligrams twice a day, and again go even higher if they're very heavy. For a very small patient less than 45 kilos, we reduce the dose to 20 milligrams once a day. And we also tend to reduce the dose when they're in renal failure. So your normal patient would usually be on 20 milligrams once a day in the setting of established renal failure. But often our pharmacists can advise on the most appropriate dose. Therapeutic anticoagulation is based on weight, and again, I don't expect you to remember all this. These guides are available on the intranet. Gastroprophylaxis is to prevent stress ulceration, and we would give pantoprazole 40 milligrams IV once a day, or lansoprazole 30 milligrams NG or PO once a day. And we give this for all patients until they're fully established on enteral feed and not ventilated. For high risk groups, it's very important to have this on because they have high rates of stress ulceration. For example, head injury, those receiving invasive ventilation, shocked patients, or those having vasopressors, people on steroids, and patients being therapeutically anticoagulated. When a patient is discharged, the drug Cardex must be transcribed to the WellSky electronic prescribing system, and we have to carefully check all drugs are prescribed correctly. Take care prescribing ICU drugs for ward patients, for example, quetiapine, trazodone, melatonin, etc., as they will often go home on this drug unless we stop it, so we don't tend to send patients out of ITU on these drugs. And again, we need to risk assess if gastroprophylaxis is still prescribed, or it will most likely continue forever. And there is a 2-person check of the electronic prescription transcribing, typically you as the prescribing doctor and the bedside nurse. Remember not to prescribe PRN electrolytes for ward discharge. If electrolyte supplementation is needed, it's better to prescribe this regularly with a stop date and discharge instructions on when to check blood tests rather than PRN. And do not prescribe IV opiates for a ward discharge except a PCA, because nurses on the ward often can't give IV opiates.